Okay. So I'll go for the session. Today I've just had some of the important conditions, which is also important regarding to the signs and symptoms of the diseases, the cardiovascular. Okay, I'm not going to focus sufficiently only cardiovascular signs and symptoms and the assessment. Because when you see the assessment questions are there, what position you give during this assessment, what is the what is that, what is varicose vein assessment, how you do. Okay, so these are all the things very important. Okay, so let us start with this. So first, before going for signs and symptoms of diseases, especially cardio, I'm discussing cardio today. Cardio signs and symptoms assessment. Especially, I'm focusing only the first initially start from the assessment, then signs and symptoms. This time, I brought you the illustration images with so that when you see, you won't forget. हम सोचते हैं palpation करो, ये palpate करो. When you see images and you do, then you won't forget. It will cover both image-based question and both. So when you go for chest inspection, so let us imagine yourself how you go to the bedside, how you start assessing the chest. So patient mostly in Fowler positioning, okay. And chest ka kya deformity? What is the deformity you have in the chest? The first deformity, the question is, yes. So the question is, we have pectus excavatum. This is the conditions, two conditions. The chest will be going inward, and we see the images here. Sunken sternum. Sternum will go inside. Ribs also will go inside. By if you see that laterally, they will be like this. Okay, and that is what first. When you see the patient self, हमारा जो chest will be normal. But if you see that chest, it will be going like this. Okay. Just a minute. Yes, good. Yes. Acha, okay. I'll share the slide. Wait. Photo. Okay, the first thing we go for this one, pectus carni excavatum, sunken sternum plus ribs. Yes. Then it may be the sign of the connective tissue disorder. Marfan syndrome. Marfan syndrome, maybe I don't know whether you heard or not. Marfan syndrome. Most of the people, those who study competitive exam, they may be knowing. Height will be more, the fingers will be lengthy. Okay, more than 7 feet will be there. When they walk, you can see like a ghost. Okay, Marfan syndrome, special condition, tall height. That is the connected. Their chest and all, like their chest is a pectus excavatum. So this is a condition. You be very clear. Pectus excavatum is your conditions where you get Marfan syndrome. And the pectus carneatum is a pigeon chest. Pigeon chest, something different, protrusion of the sternum and ribs. Okay, pigeon chest. Pectus carneatum, pigeon chest, like how you studied in your barrel chest, in your MCQ. Okay, so in the chest, what kind of problem or ho sakta hai? What may be the problem? Next problem, signs of trauma. Plial chest is exam question. Agar one fracture, more than 3 or 4 multiple fractures hai, wo plial chest hai. Okay, so that is also very important here when you think about this plial chest. Yes, from fractures along the chest wall, more than 1 or 2, 3 fractures is a plial chest. And the crepitus is always question of your previous year. Whenever you see the crepitus sound, doctors usually assess the sound, crepitus sound during inspection when they palpate subcutaneous space or anywhere. Clicks. Yes, it's like a rails and crackles. Crepitus cracking sound, like from, yes, some sound will come. That is known as, especially in the subcutaneous tissue. That is also you have to assess. That is also crepitus. So chest may what all thing problem they may have. This is a problem. And come for the head. When you think about head, what may be the problem in the head? Head may we can divide eyes, mouth, and neck. Major part. Eyes may what are the MCQs may get? Pallor. When you think pallor, image you can see that pallor indicates basis anemia. Basically, you know that. So suggest anemia, assess generally pulling. Now the question is, how you assess the pallor? ESA question, how it? Nurse is assessing the patient for anemia and assessing the congenital pallor. How we are going to assess? Answer 1. Gently pull the this one upward, eyelid or lower lid. ESA questions and you get confused because we are not doing the assessment. So you can see the assessment by gently pulling down the lower lid or lower outward, lower inward or upward. To make confusion, they may give. Generally pull this one, make the patient tell to look upward and just you pull down. So that is what actually we do for the congenital pallor. This is a special finding which is there related to anemia. Okay, special finding which is related to anemia. Then next MCQ is corneal arches. So there is a condition where corneal arches, I have all the images, we have all the images, सारा images है, okay. Corneal arches yellow ring, eyes में जो yellowish gray ring, which indicates hyper increased level of abnormal level of cholesterol, total cholesterol in the iris, indicates hypercholesteremia. That is corneal arches, which is the exam question MCQs. Okay, the definition they may ask. Okay. Xanthoma and xanthelassemia is another MCQs. It's a yellowish ring. You can see the difference between the corneal arches and the xanthelassemia. So there is a difference here. When you see that corneal arches, there is a ring, yellowish grayish ring. Xanthelassemia is a yellow raised lesion around the eyes. Always the confusion, mostly get confusion here. Okay, yellow raised lesion around the eyes indicates once again hypercholesteremia. Come for the mouth. Mouth में तो आपको assessment I tell most of the questions of MCQs based on the assessment. We study everything. This is condition. Finally, they will put on the fundamental assessment of the patient. Okay, since we are not doing assessment, we are not aware about what is it. Okay. Okay, so central sinuses and we study peripheral sinuses. एक तो central sinuses पूरा इधर होगा sinuses, एक तो peripheral sinuses fingers में होगा. वो central sinuses, fluid distillation of the lips, indicates lower, which we'll see in the most of the heart disease. We can see peripheral sinuses only in congenital heart failure. Apart from that, we can see the Burgess disease, vascular problem, PVD. These are all the conditions where the peripheral sinuses are most common. Then, what is high order palate? Palate, I'll show the image and I will explain. This also goes for the Marfan syndrome. Dental hygiene in the mouth, dental hygiene is always indicated for the infective endocarditis. That's a direct question. Whenever whenever you see the infective endocarditis, directly you should go and assess the patient. Take the dental caries. Dental hygiene is a very important priority nursing intervention for the infective endocarditis. Head, neck. Now, mouth is important key point. Congenital pallor exam question. Corneal arches also they can ask you. I told you it is a UPSC preparation. Better we can prepare in the deep. Superficial also we can cover. Deep also we can cover. So question can cover. You can be very confident. आपको confident होगा before the exam. Then you have neck. Neck में तो mostly JVD, distension of jugular venous pressure. By assessment, you have to see this jugular venous is distended or height it's increased 6 to 8 centimeter. Patient should be in polar positioning. How you assess the jugular venous pressure? We are not doing. It should be polar positioning, 45 degree. They may ask the supine, prone, Trendelenburg. How you assess the JVD? First assessment से आपको start करना होगा. Mostly you have to start from the assessment. How you assess the JVD? Okay. Diaphragmatic exploration I will be coming last. Okay. All the diagrams I have the last. First you study the theory. Then come for the image. I have all the images. Okay, you can see all the images I have. So at last, once theory part is completed, so we can see with the images. Okay. See. So I have all the images one by one, complete cardiovascular image, complete whatever terms we are using, so that there should not be any confusion. Okay, xantholimas, everything images. Through images only this class I'm going to take. How we are going to use the stethoscope. What is bell? What is diaphragm? A question there. Bell, where you use the bell. हम use नहीं करते, but you should know where the diaphragm, how you auscultate, where this is the chamber, where this chamber, everything image is there. I'm showing now itself. Okay, today will be the interesting session till image illustration based questions. Okay, till last will be cardiovascular examinations and signs and symptoms as well as. Okay. So motto of this, when you study, you have to be very clear in the cardiovascular assessment, positioning, what you do, and everything. Okay. Yes. So JVD 30 to 45 degree. Yes. JVD is 30 to 45 degree. Locate the external jugular. They are not assessing the internal jugular vein. They are assessing the locate the location. They are doing location. I will show the image, next image. As it crosses the identify point of maximum JVD from the. Just a minute. Okay. So increase distension, you know what is the problem. This is the MCQ. JVD distension, we studied in congestive heart failure, increase distension jugular vein pressure. JVD is increase, JVD increase. Where? Hyperolemia, congestive heart failure. Okay. If it is decreased, maybe hypovolemic shock normally. Okay. Now, images you can see how they are assessing the JVD. With the 30 to 45 degree positioning, we have to assess the JVD. Okay, 30 to 40 degree, 30 to 45 degree, you assess the JVD. Okay, so this is the way. If jugular vein distensions are there, it's always indicated of congestive heart failure. When JVD is increased, it's always congestive heart failure. Okay. Now, we finished mouth. We finished important in the mouth. Not everything. Cardiovascular assessment of the mouth. I'm not discussing physical examination of the mouth. We are discussing only cardiovascular related assessment of the mouth and neck. Okay, and what is studied? Eyes. Okay. Now extremities. What is the cardiovascular assessment on the extremities? You get finger and nails abnormality. Hypoxia is a major problem for cardiac related disorders. Clubbing is another problem. Clubbing, you know, swelling. We can see the images. Clubbing of the fingers suggests chronic hypoxia. These are the basics. हम तो यही तो बोलूं, deeply study करने के बाद basic जो है, if you leave this one, they may ask which are the following suggest the patient going for clubbing of the finger. That means suggest chronic hypoxia. Chronic hypoxia, not an acute. Then sinus of nails suggest also hypoxia. Splinter hemorrhage in the nails suggests septic emboli. We are going to see the image. Extremity may, if we make the patient to show the hand, there is a small splinter hemorrhage, which you will see the image. Septic emboli, which is seen in the infective endocarditis. Okay. So this is also important assessment. As a demo session today, I'm giving some of the important only. So this is as the regular batch. We are going to take the pattern this way. So inform the faculty also to add many images. Oscular node, tender red nodules on the finger pulps indicates infective endocarditis. We see the image. January lesions also, we can see the image. Lesions in the area, palms and everywhere. Okay, so maculopapular lesions on the palm here. Okay, small lesions will be there. With the image we can see. And oscular node will be some necrotic node, tender red nodules in the finger pulp. Pulp this area. Okay, this area. Finger pulp, the gap is your pulp. Okay. Capillary refill time though, सबको पता है mostly. it should be less than 2 seconds, not less than 3 seconds. In many books, it given less than 3 seconds. It is less than 2 seconds. Capillary refill time less than 2. If it is prolonged, what may be the answer? Patient is in. Basically, you are assessing the capillary refill time. The nurse is assessing the capillary refill time, and the capillary refill time is prolonged. Which of the following findings suggest? So basic thing, it's a hypovolemia. Clear? Patient going for hypovolemia. So less than 2 seconds ago hypovolemia. Normal is less than 2 seconds. If it is prolonged more than 2 seconds, that indicates hypovolemia. And cardiovascular assessment of the extremities, tear stain. Some staining will be there in the finger for the chronic smoker. अब देख 30-35 years में जो smokers है इसको हाथ देकर ऐसे हो मतलब the fingers and everywhere will be tar staining will be there. Indication of smoking, which indicates risk of the cardiovascular disease. So for new joiner, once again, the classes will be in 2 modules. One is English and Hindi and English. Okay. English and Hindi will be the Delhi branch hybrid classes. Those who are joining online hybrid, and only English will be there for the South branch, which is from the Puducherry, live from the Puducherry. Okay. See, one day taking notes is difficult. This is demo class. Okay. We upload the slide for our students. Same slides will be uploaded in the app. You can take notes by your own. Okay. Slides को upload करते हैं हम लोग. So same app recording session. ये same slides will be uploaded. So you can take the notes. Okay. These classes will be mostly in English, and next sessions from Monday there is a separate session Hindi and English both. Okay. So there will be separate session for Hindi and English. This is only mostly I'll focus for English as majority of from the southern region. Okay. Right. So here you can see cool peripheries may suggest poor cardiac output. You are very clear. And sweat, clammy skin. Yes. Suddenly patients going for sweaty, clammy skin. Profuse sweatings are there. What you may suspect sudden profuse sweating to patient go for acute coronary syndrome, that is especially MI. See, I'm giving the idea and all, you will come to know. Okay. Just now you are going to now your first time or your last time, you will get an idea of how to write the exam. Coding sheet, 100 marks question, you are going to share the paper, not online. Okay. You put a round, practice the round, shading you have to do maximum. Okay. Coding sheet you have to download, OMR sheet, take a print and keep it. Okay. And you can daily when you are practicing questions from the app, we can give, you put a coding sheet and mark and round it and practice. If you scribble that rounding also, 1 mark will be gone. If you should not go out of the round. Okay, that is a special of this ESA. This round is very important. We have to, if you are doing like this also, it won't calculate. Answer is wrong. Completely should be fully black. Okay. By some, you people can ask doubt last. Okay. Don't ask the basic doubts. Okay, I'm having the session. At last, you can ask the doubt. Please don't ask any basic doubt. How to write the exam? How to negative marking? How to one day you won't learn anything. Okay, this is just we are giving demo. Day by day, if you are continuing the classes, you will come to know. Okay. Okay, if you find it hard to catch up, it is not our mistake. It will take time. If you are studying for a long time, okay, it will take time. And moreover, I will tell once again, I'm giving recording bhi hai, not demo session. Only the sessions from Monday you will get recording. So you can see maximum 15 times. You can see the recording. You can learn. Okay, and slides also will be uploaded as a notes. Okay. So peripheral edema. This is the key point. Peripheral edema is a sign of the congestive heart failure. Okay, peripheral edema is a sign of the congestive heart failure. All the students will get recorded live slides and everything, where those who are continuing the ESA. Okay, so don't worry about you are not able to take notes, you are not able to listen, the class is fast, nothing to worry. You can see the recorded session. Live recorded, not recorded. It's a live updated recorded. So you can see more than 10 to maximum 15 times you can see. One session you can see maximum 15 times. Okay. So here, what is the sign of the congestive heart failure? Peripheral edema. Peripheral edema is also good sign for when you are going to the bedside, when ankle edema is there, foot edema is there. It is because of hyperolemia, left ventricle failure, that is congestive heart failure. Okay. Next. So, palpation. So, cardiovascular assessment of the inspection. So, we have seen chest, right? We have seen chest deformities, chest of trauma. What are the problems related to chest? Glial chest also causes respiratory failure in the chest, and head, eyes, mouth, and we have studied about neck. What is the important neck? Okay. And extremity, what is important? Extremities, we are assessing hypoxia, chronic hypoxia, peripheral edema, tar staining, smoking, capillary refill time we are assessing, Janvel lesions we are assessing, and oscular nerve suggestion infective endocarditis, and septic embolism, splinter hemorrhage also they are assessing. Palpation. Next is a palpation. So palpation of the chest wall. What is precardium? So you know that precardium, people, doctors usually that precardium space is your above the chest wall. Precardium is your above the chest wall. Just a minute. So precardium, what is precardium? If you see the precardium here, see this is a lamp, how we are assessing this one. So this is the palpation of precardium. This is the precardium, this area, how heel of the hand over the sternal border, fingers below the left nipple. Everything doctors actually, cardiologists, we also study the physical examination. Since we are not doing the physical examination, it's not proper idea. We don't have that much of idea. Okay, we don't have idea. So precardium, we have two important. In cardiovascular assessment, brachial pulse is important. So we may be studying about narrow pulse pressure and wide pulse pressure. Direct question. What is pulse pressure? You know that difference between the systolic and diastolic pressure. What is the normal pulse pressure is 40, because when you minus 120 minus 80, normal pulse pressure is 40. What is now the question is, what is narrow pulse pressure and what is wide pulse pressure? Narrow pulse pressure is less than 25, usually we tell, which is seen in aortic stenosis. Wide pulse pressure is major condition, cardiovascular condition, that is aortic regurgitation. Wide pulse pressure is greater than 60. These are all important questions in your advanced level. Even UPSC also writing the exam preparation. Maybe I told you, don't stick into UPSC, will be simple pattern. Okay, if the tough questions are there, you should be able to write the question, because there is no aptitude reasoning. So the question paper, they be standard question paper. After 4 or 5 years, the question paper is coming. Okay, so better study everything, that will be good. Less than 20 is your narrow pulse pressure, that is cardiovascular assessment, most commonly seen in aortic stenosis. Greater than 60, which is seen in the aortic regurgitation. So carotid pulse, palpate pulse between the sternal fluid and trachea. We palpate here. Okay, you know the exact palpation of the carotid pulse. Slow raising indicates aortic stenosis. When you palpate the carotid pulse, usually carotid pulse is it's feeble, good. If it is slow rising, that indicates aortic stenosis. That will be one more finding here. Okay, slow rising, that indicates aortic stenosis. Aortic stenosis will be studying in your disease condition. Okay. Now, how they are assessing? As I said, the most important thing here, identify the point of maximum impulse where the heartbeat has this one. So, which is the maximum impulse? Usually it happens in the fifth intercostal space. Mid-clavicular line is your maximum impulse, where the doctors will assess through the palpation. We can keep the hand, they can assess. Now the question is, we should know what is a little advanced deep level, what is thrill or thrust. This is the little deep word. हमने जो study किया that is different. Thrill, back by the dialysis patients, graft, assess the brute and thrill. So we study in the renal. But here, in cardiovascular assessment, what is thrill and heave and thrust, it should be very clear. I have not discussed for you also. आप लोग भी please take the notes. Okay. Here, thrill is a vibratory sensation made by the turbulent blood flow due to valvular abnormality. So you can see the thrill is a vibratory sensation made by turbulent blood flow due to valvular abnormality. Okay. So heave is a thrust, is an impulse in the left parasternal area, indicates right ventricle hypertrophy. So it is an impulse, special impulse in the left region, low parasternal. This is what assessment. They are assessing here with the help of hand. This area they are assessing, which I said, they are assessing the third and fourth intercostal space, which is having impulse in the left low parasternal area. This is the low parasternal area. Okay, and that they are assessing that this heave and thrust is impulse. It is impulse in the left low parasternal area by intercostal space 3 and 4 indicates right ventricle hypertrophy. It is some of the important finding palpatory for the doctor. Who knows? They may put a question. The nurse who's doing the assessment for cardiovascular examination, okay, and the patient's having thrill. So what does it mean? It means that you are assessing, doctors, they are assessing turbulent blood flow due to valvular abnormality. It's a turbulent blood flow due to valvular abnormality. And moreover, it's a vibratory sensation. Murmur is different. Now, murmur is different. We have studied in your cardio. It's a vibratory sensation, and that is little different from murmur. Here is a sudden spike impulse in the low sternal area, sudden impulse in the low sternal area, which is palpated by the below the third and fourth intercostal space. That indicates right ventricle hypertrophy. Okay, auscultations. So auscultations, once again, important that auscultation of brute, which is also best performed on the bare skin. Best. What is a bare skin? Well, open. Yes, good. Without hair and without cloths. Maintain the individual everything performing maneuvers on the chest. So brute. Now I want to give 2 MCQ, which you will get in your exam. Doctors, they are using bell and diaphragm. Bell, last year before also question came. Bell where they use, diaphragm where they use. Bell and diaphragm. Bell they use for auscultate low pitch sound, which indicates murmur. Mostly to rule out murmur, opposite they will keep. Bell, you know bell. I hope everyone knows the bell. This is the bell. This is the diaphragm. When they turn and keep, that means they are going to find the murmurs, low pitch sound. Okay, bell and diaphragm, sorry. And the brute sounds also, which is related to stenosis, also they can assess. Diaphragm is used for any other sounds. For auscultation, usually diaphragm they use. Bell is specially used for the murmurs. So MCQ. Whenever you find MCQs, you have to be very clear. This also will be the MCQs. Okay. 6:30 I will take session, then sir will come offline. Gaurav sir will become. Okay. So if you see that auscultation, people are aware of auscultation. Where is the aortic valve? Where is the pulmonary valve? Where is the tricuspid valve? And where is the mitral? So right second intercostal space is your aortic valve. Left second intercostal space is your pulmonary valve. So you can see that here, the image-based question. So image-based questions are famous here. They can give. You can see the aortic valve, right? You can get the pulmonary valve, and auscultation image-based hotspot question they can give. Now it is written ADM. For freshers, you should know very clearly. If auscultation is that image-based, video-based questions, okay, any exam, maybe NORCET. So I told no, we have to cover everything, NORCET as well as ESI. Okay, so T and mitral apical pulse is very important. It is a hooked intercostal space. Okay, hooked intercostal space at mid clavicular line, mid clavicular line. Heart sounds. S1 is the first heart sound, makes the beginning of the systole and the end of the diastole. Okay. So where it is loudest. Now the twist is that we all know that S1, what is S1 sound, what is S2 sound. Generally we study. But where it is seen, S1 sounds is the first heart sound, marks at the beginning of the contraction and end of the relaxation. Okay. So S1 sound of the closure of mitral and tricuspid valve, loudest at the apex. What is where is the apex? Yes. In heart, here is the apex. Base is here. But in the lungs, opposite. Here is a base and apex is the upper side. Just opposite. Okay. Clear. So now you got a question here. S1 sound will be loudest at the, even though we study this love sound is the first sound here between the closure of the mitral valve and tricuspid valve, but it is loudest at the apex. Okay. Precedes the carotid pulse. If you they palpate the carotid pulse, they will access. S2 is the dove sound, love dove. Usually we study love and dove. And the dove sound is second heart sound. So sometimes they ask when it is occurring. First, simple question. S1 sounds when it is occurring. Option 1. End of the systole, beginning of the diastole. Beginning of the systole, end of the diastole. If you are not focusing properly, here also we do the mistake. Very simple question only. S1, beginning of the systole. We usually study S1 is the closure of the mitral valve, tricuspid valve. But when you think about other side, contraction, relaxation, beginning of the systole, end of the diastole, S1 is seen. S2 is end of the systole and beginning of the diastole. And this is a like twisting question will be there. UPSC people want to give, as I said, usually doctors are taking questions, so their level will be that question. For them, it is basic. For us, it will be that twisted question. For their level, it will be basic. Committee members will be there, nursing, doctors, everything. As you know, future investment for nurses, practitioner, everything is more. So, advanced level of questions, learn and keep it. If it is basic level, no problem. So, you can basic level, if you study advanced level, basic level, everyone will clear. Okay. So, end of the systole and beginning of the diastole is your, yes. S1 is the first heart sound, makes the beginning of the systole and the end of the diastole. S2 is a second heart sound, makes the end of the systole and beginning of the diastole. Okay. So there will be for those who are messaging, there will be two or three special demo for northern region student. Those who are looking for Hindi and English. Okay. Once again, the demo will be there for you people. Okay. From Monday. Okay. So it is loudest at the base. And after the carotid pulse. So after carotid pulse comes or not? Immediate precedes. See, what is precedes a carotid pulse? Precedes means before or after? Before. This is even aptitude reasoning also will come. One number precedes 7 is precedes 6. 6 is precedes 8. So you know that number is coming. Carotid pulse precedes. What is precedes? Precedes means just before the carotid pulse. You have S1 sound. Just before the carotid pulse. After the carotid pulse, you have the S2 sound. Right? So this is an important heart assessment. Usually we study S2 sounds between the aortic and the pulmonary valve. But here S2 sounds after the carotid pulse. S3. S, the third heart sound, always abnormal. It's known as ventricle sounds, ventricle gallop. S3 is a ventricle gallop sounds. Okay, S3 sound is a third heart sound. It's a ventricle gallop. So you can see here, S3 sounds are abnormal in some condition, congestive heart failure. Mostly, S3 sounds are found in the congestive heart failure. So occurs just after the S2 when the mitral valve opens, produced by the large amount of blood striking a left ventricle, which is not pumping out of the heart failure, especially congestive heart failure. S3 is often heard in the systolic heart failure, that is left ventricle failure, that is congestive heart failure. S4 is a fourth heart sound, atrial gallop. Gallop is abnormal sound, abnormal finding. So don't worry about this. Abnormal sounds always, abnormal sounds or extra sounds are comes under gallop sound. Ventricle gallop S3, S4 is just before the S1, it's atrial gallop. S4 is often heard in settings of the cardiovascular ischemia and also cardiomyopathy. Poor prognosis. Two conditions you have to write and keep for the S4 sounds. S4 sounds just before S1 and sound of the arteria contracting to the post completely non-compliant because the ventricle is not functioning. Non-compliant left ventricle is left ventricle compliance is gone. Left ventricle is not working. So that is what non-compliant. So that is what actually S4 sound, poor prognosis. Whenever S4 sounds are there, it's a cardiomyopathy or ischemia conditions. Poor prognosis. Okay. In adult, sorry, in athletes, some of the athletes, sports person. Okay, S3 sounds are normal. They consider for young adult 30 years, who's 30 years, and they have this one. And they consider normal for the young adult, for the athletes. Okay, not for everyone, only for the adult age group of 30 years, athletes, strong athletes, S3 sounds are this one because they are very, they go where they, even their heart rate will be in borderline only. We think that athletes having a tachycardia, they may, since they always running and keep on body fit, their heart rate will be 55, 60, borderline 60. Why? Because the mechanism which I said, when the contractions are more, actually pumping rate will get decreased, and actually that is the physiology which you study in your cardio. Mostly all the athletes will be having the borderline. When they run, it will increase. For us, what happened? For us, if we run, it will increase. But once we are rest, it comes to a normal stage, previously 90, 80. But for them, what happened? It comes the normal stage to 60, 65. Athletes always have that one. So that conditions, S3 will be, they have the normal. Rub sound produced with the inflammation of the parietal. So pericardial rub. हम तो ये भी important है. This is also important. Pericardial rub sound, yes. Creaky, scratchy, noisy sound heard in the auscultation. Now key point you can write. Whenever you see the question paper, creaky, scratchy noise sound, it is a rub sound. हम तो confuse करते crackle, ronky और ये वो मतलब many sounds are there. When you see the creaky and scratchy word, that is your rub sound. The sound produced with the inflammation of the parietal and visceral pericardium. Yeah. Okay. So this is very good. And then murmurs. Murmurs are always important. As I said, what we study in your regular batch, I added some little deeper one. So if you want to study, you can study. Otherwise, no issue. Murmurs always abnormal, sudden gush of blood from one area to other. You can see the murmurs. So we are not going to ask you that the murmur, but we can think, as I said, we have 3 condition-based murmur. You can tell what Caricom's murmur. Exam point. As I studied in your regular class. Caricom's murmur seen in. Austin Flint murmur seen in. Caricom's murmur seen in mitral valve defects. Austin Flint murmur seen in aortic regurgitation. A for A. Aortic regurgitation. Okay, aortic regurgitation. So Caricum's murmur, which is seen in your Caricum's mitral valve defect, mitral stenosis, mitral valve, Austin Flint murmur, seen in aortic. One more murmur is it, Graham Still murmur. It's a condition-based murmur. Pulmonary condition, pulmonary stenosis. Pulmonary stenosis. Graham Still murmur. Apart from that, usually doctors, they have their own guidelines, they have their assessment. You can, this is additional learning. There, the condition-based murmurs they disclose. Here, normally, physical examination murmurs, they have three types. One is systolic murmurs, that means mid-systolic murmur, late systolic murmur, and pan-systolic murmur. Very rare questions, but still you can write and give, because when you see the physical assessment, cardiovascular assessment, how the doctors are doing, it's a basic for us. You can write we are not going to do assessment. Mid-systolic murmur seen in pulmonary stenosis or hypertrophic cardiomyopathy or ASD is also MCQ, mid-systolic murmur. Okay, increased flow through the normal valve, aortic stenosis, they can see, and late systolic murmur seen in your mitral regurgitation, okay, or infective endocarditis. Two conditions you can try. It is due to papillary muscle dysfunction, late systolic murmur. Pan-systolic murmur is completely VSD. I think better directly you can go for MCQ. ASD may which murmur is seen, mid-systolic murmur. They won't ask, but still you can write and keep, because general examination of the patients, cardiovascular examination, usually what we do, nursing process. We do identity data and chief complaint, present complaint, we write our own story. So permit, subjective data, objective planning, assessment, nursing process. Same physical examination, cardiovascular examination, it is a mandatory to assess the murmurs if they have the condition. Okay, so this is ASD, which is seen in your APO. ASD may mid-systolic, VSD may pan-systolic murmur, and late systolic murmur seen in your infective endocarditis or mitral regurgitation. Okay. Diastolic murmur seen in your, yes, aortic regurgitation, you can write, pulmonary regurgitation, you can write, aortic and pulmonary valve. It's a semilunar valve, right? Both we can see diastolic murmur. Okay. So apart from that, we can come for the cardiovascular signs. Now, you can see the images which I want to tell. So images, see, when you are assessing, I want to go with the direct question in your exam. There is a difference between the image-based finding. We are going to discuss now image-based finding. Then I'll come for the, when you are assessing, there is a difference between the radial pulse and the apical pulse. That is pulse deficit. Radial pulse and the apical pulse. That is pulse deficit, which is seen in the atrial fibrillation. Repeated question. Pulse deficit. Here, radio delay. Both the radial pulse are delayed. That is seen in your aortic regurgitation, aortic coagulation. So this is the, when there is a radio delay, both you are palpating together, and both values, one is coming to 72, other should also come to 72, and in one comes to 68 same time. So there is a delay with the radio. That shows the patient going for aortic regurgitation. I'm giving directly the finding, important finding. Oscular node, yes, finger में necrotic finger pulps. You can see that oscular nodes, finger pulp, this area, pulp areas will get damaged, become, which you have seen now. This is the typical one of the features for the infective endocarditis. Okay. Janvial lesions, हमने discuss किया now. Lesions in the palms, you can see in the palm how small lesions are there. You can see the small lesions, Janvial lesions in the palms. Okay. Splinter hemorrhage, We have studied splinter hemorrhage, image-based question also they can ask. Be used for any exam. When you see that this kind of finding, that is also one type of infective endocarditis. Okay. Finger clubbing, image-based question. See the finger, the nail, how it's clubbed here. Am I right? How it's clubbed? It's a finger clubbing. See the difference of clubbing here. Finger clubbing seen in good chronic hypoxia. Good. I didn't discuss this. Long, you can see that finger. These are all finding which you can easily. Fingers are long. Now we see Marfan syndrome. Fingers are long. What is the finding you can tell? This is known as arachnodactyly. Some of the findings in the cardiovascular assessment, Marfan syndrome. Okay, they have a long fingers. You can see it's known as, yes, long finger is arachnodactyly. Yes, increased level of cholesterol, hypercholesteremia, image-based question, important finding. I'm not taking the session which is out of your subject. It's a subject which you have not learned. Okay. Xanthometa, xanthometa, both are same. Increased level of hypercholesteremia. They get structures like this. That is known as xanthometa. Okay. Xanthometa, xanthometa, which we have seen. Okay. Image-based question. This is the chronic smoker. Yes, tar staining on the hand. Peripheral sinuses. Generally, they've given and they're asking peripheral sinuses. What condition? Congestive heart failure. Also, it is seen. Okay. Pallor. Compare both. Pallor due to anemia. This is you see that, and this is you can see the difference of that pallor. Xanthomatous we have seen, tar staining we have seen, and oscular mode both we have seen. Yes, this is the finger clubbing. Already I have discussed. There's a usually you do and see yourself. Usually there is a gap. Everyone having the gap, small gap. Yes, even I also have. Yes, sir. Small. So that is normal finding. Last gap is not there, then there is a finger clubbing. Emphysema, severe case of emphysema patients they may be having. That is known as Scam-Rose windows. The name they can ask that is known as, yes, Scam-Rose windows test. Last with the finger clubbing. Okay, it will be bigger, swollen. There is no this one. Okay. Capillary refill time less than 2 seconds is a normal. Most commonly, where to check it, not go for a leg, better. Any question they can ask. Okay. See, capillary refill time, go and assess the capillary refill time. You should not go and think where to assess the capillary. In the air, or in foot, or finger, you can assess. General assessment, I'm not telling anything, generally assessment. Okay, capillary refill time less than 2 seconds are normal. Right? Yes. You see the murmurs, especially bell they have used. Carotid, anything which is related to carotid issues or murmurs, asking that the carotid artery, especially through the bell, how they are asking. Coarse crackles, I have not discussed. Pulmonary edema, we have discussed in this one. Pulmonary edema patients, they have the coarse crackles. Always important, crackles are the previous year question. Crackles are assessed in your base of the lung. This base of the lung. This year, last NORCET album came, I think. Vesicular sounds are most commonly seen in the periphery. Vesicular sound, that is base of the lung. Post crackles are seen. Crackles are one of the important finding in your hyperolemia, left ventricle failure, pulmonary edema, everywhere. So pulmonary edema secondary to the left ventricle, always post crackles are seen. Where you are assessing, where they are assessing in the base of the lung or posterior lung sides. These also not in the anterior side, posterior, that is also good. Hospital crackles are best in the ARDS patients, pulmonary edema patients. Those crackles are seen in the posterior side of lung, where you can see major crackles are. Confirm that patients going for the ARDS. Okay. Pedal edema, pitting edema, pedal edema, different. pitting edema, press and see. Pedal edema, generally you can see palpitancy, both area, in this area. Pedal edema is always increased though, that is right ventricle failure. Okay. Sacral edema, also like right ventricle failure, right side failure. Pedal edema, right side failure. Okay. So auscultations, now the image-based questions. Generally, I've given the name here, so no problem. In the exam, generally they give the chest wall and they're given here. So basically, we should know this is the mitral valve, apical pulse where the mid-clavicular. Okay. So we have seen already yearly pan-systolic murmur is seen in the yes, mitral biggest. हाँ VSDB है mitral
का late
नहीं aortic reason pan-systolic let me check. Let me check. Okay, let me check. Let me check. So pulmonary valve, aortic valve, and then pulmonary valve. Second side we are processing, and then tricuspid valve, then apical valve. So here they give the image that is aortic valve. Okay. Second intercostal space. Repeatedly they want to assess the auscultation 4 heart pulse, apical pulse. Repeat auscultation of 4 heart pulse using the bell of the. Once again, if you want to assess clearly whether sounds are very clear, they go for the use the bell. So bell is used to assess the low intensity sounds. Yes, and diaphragm is used to assess the another high intensity sounds. In hand, when you are assessing, all the patients should be placed in a semipolar positioning 45-degree. And color cyanosis, pallor, erythema usually assessed. Fingertip necrosis always. Whenever you see the fingertip necrosis, see, you can't able to do recording, you can't able to take screenshot. Okay, it is completely protected. It is a demo. It is completely protected. We don't have any of this one. Those who are asking message. Okay, you listen the class. Don't think we can do that. This we don't give anything. It is our students only, those who are learning from outside. Okay. Yes, fingertip necrosis is Burger disease. Okay, and tar staining is smoking. And tendon xanthomas also, tendon also, limb pallor also we can assess. So hand way we can assess this much. And murmurs they are assessing for the ejection systolic murmurs. Also one more systolic murmur, doctor's point of view, they are assessing the murmur in the carotid arteries. Murmur, why I have given this slide? Bell of the stethoscope is used for the murmurs. So that is a question you have. Bell, not in the diaphragm. So peripheral cyanosis we have discussed. Next come for the signs and symptoms of the disease. So images, some of the images I covered. Yes. Okay. Yes. Apart from the images, this also we can complete. So now respiratory rate assessment. You are informed to assess the respiratory rate. Which of the following position due to the patient? Same. Patients lying. Patients should be. This is the common position. Why I want to give cardiovascular assessment. All basic questions. Respiratory assessment. Patient should be comfortable. Polar positioning, semi-polar, 45-degree. Okay, and we are assessing the respiratory. Sinuses we have discussed. Yes, this you all know that is findings which are not discussed. Astrovaxis, which is also important finding in the CO2 retention, is the physical finding for the patient who is going for any Any cirrhosis of carpulmonary, any conditions whose lung secondary heart disease going to the, so lung disease going to the heart disease, severe lung disease. Why this is added here? Chronic lung disease, carpulmonary. One condition is there, carpulmonary. Chronic bronchitis or condition, they go for right side failure. In that condition, so you can see that kind of this CO2 is retained, and that is going for hepatic condition. CO2 is retained. CO2 is retained. So when the CO2 is retained, they go for more respiratory acidosis, and they go for confusion, and go for CO2 retention, and patient mostly CO2 retention you can tell. Apart from that, cirrhosis of liver, hepatic encephalopathy, these are the area where liver flappy tremor and the liver disorder we are assessing. Basically, why it is coming the cardiovascular assessment? Because of your carpulmonary conditions where heart bronchitis or any condition, chronic bronchitis, O condition go for the right side failure, where CO2 is retained. Bronchitis patients chronically CO2 is retained. So that patient they can get Astor access. Okay. Flappy tremor. How you assess flappy tremor? Now, if we are holding like this. Okay. When you are going for this flap tremor, if they won't be like this. Okay. Keep like this. Okay. So here we are making, if you are informing me, I will be keeping like this. Patient with CO2 retention over and patient condition, they can't able to hold. This is the flappy tremor. What is the fine tremor which is seen in your what is that? Pill rolling fine tremor. Many conditions we see. Generally, normally assessment. Old age also fine tremor. And I'll come for that. But here, exam question. I didn't discuss tremor. We studied the salbutamol. Tachycardia and hypokalemia will be there. Nebulization, aspirin, salbutamol dose overuse of salbutamol. They get the side effects. Fine tremor. In this book, if you see tremor is there, but fine tremor, it's better to write clearly. Fine tremor is seen in which conditions? Usage of side effects of the salbutamol. Aspirin nebulization, we are using one of the most common beta 2 agonist. हमने discuss किया ना, वो discussed in your respiratory drugs. Beta agonist use always causes salbutamol, which causes fine tremor. Once again, important question from the image-based question. If someone is assessing the pulse here, you should know that is dorsalis pedis pulse. Okay, it's very important. Why it is important? Dorsalis pedis is also very important. Absence of the dorsalis pedis pulse, patient going for hypovolemic shock. Doctors, many times I told you I assess the radial pulse. Doctors will assess dorsalis pedis pulse. Radial pulse will be there. Dorsalis pedis will be there. That goes for patient going for shock, hypovolemic shock. So this is also important. So this is the popliteal pulse. Basically, you all know that popliteal pulse located here. This is the normal assessment. Supine, I can put a question. How we are going to assess the popliteal pulse? Supine position, supine dorsal recommend. Supine, this is the supine plus maybe supine dorsal cross. This knee extension is recommend positioning, right? So place the patient in such a positioning, and they are assessing with both hands here. Popliteal, located in the inferior region of the popliteal. As if you go on keep, they can assess the pulse. Popliteal pulse important. If you are assessing the pulse here, mostly that is your yes, posterior tibial pulse. Posterior tibial pulse. So this is also important. Where up lateral to the medial, this is a medial malleus. Tibia, this is your tibia. This is your medial malleus. Lateral to the medial malleus. Exact location I said in your cardiovascular class. Lateral to the medial malleus, we get posterior tibial pulse. Okay. So Brute, I said Brutes they are assessing auscultation. Some of the auscultation femoral pulse, usually exam-based question, femoral pulse where they are assessed. Okay, associated with auscultated femoral Brutes or pulse, associated with femoral or iliac stenosis. Mostly stenosis patients they can assess. Okay, or femoral pulse if they are calculated, you can calculate in such a way femoral pulse before taking ABG. Radio femoral delay. There is one more question. Radial apical delays pulse deficit. Radial delays aortic coagulation. Once again, there is a problem here. Radial femoral delay also aortic coagulation. Okay. So these are all very rare, but it's important in the assessment. Not every time same question can come. Okay. So radial femoral delay, radial apical delay is pulse deficit. Radial delay is aortic coagulation, and radial femoral delay also aortic coagulation. So this is what location of your femoral pulse. Locate half of the between anterior superior iliac spine and the symphysis pubis, where they are assessing the femoral pulse. Okay, location of the femoral pulse they can ask. Mid-angular point location located halfway between the anterior superior iliac spine and the superior, yes, symphysis pubis. What is this image-based question? Have you heard this one? I have not mentioned the condition. Anyone? One test. This is a test. Woman sign. No. If you remember my cardiology class, you may be writing. DVT, no. I given one example. Bed, corner of the bed, patient will come and sit, elevate the leg, and then. No. 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 Anyone? No. Okay, I will tell. So, parallel versus Burger-Salins exercise in the PVD. Burger-Salins, this is the, I told patient will do themselves, but here one person Burger-Salins exercise. Development of pallor in the Burger's disease, usually they will lift the limb and then they'll keep the limb straight, and they have to, you can see here, they keep the straight, and then they'll, third image, they'll keep the limb down. Okay, so they will see the pattern of filling. Burger-Salins exercise, which I said, which is used for the peripheral vascular disease. Okay, special exercise for the, which one? Thromboangiotensin obliterans, that is Burger's disease, which we have studied. Burger-Salins exercise. Okay, it's a assessment part. To assess the Burger-Salins exercise, they will go for this finding, observe development of pallor, and see that whether raise both of the patient's feet 45 degrees for 2 to 3 minutes, and then they will assess the temperature. Yes, for the cold limb, it is PVD. Where is hot limb, it is cellulitis and DVT. This is also important finding. It's a type of Burger-Salins test. The exercise though we can do. Burger-Salins test. Leg upstairs, then down, and then down. They will see the pallor as well as they will see the limb. Cold limb, it is PVD. If it is hot limb, it is cellulitis and DVT. MCQ. How the assessment happening in the periphery. Okay. It's a Burger-Salins exercise, also same pattern. It's a Burger-Salins test. PVD is peripheral vascular disorder. Peripheral vascular disorder, where, okay. So general infection. Generally, if question is, the nurse is advised to do the general inspection of the patients. Simple question. Which are the following positions you prefer? Supine, high forward, standing. So, general inspection also, patient should be in the polar positioning. Okay. Patients comfortable, no scare, sinuses, all things they'll be assessing. Okay. That study we have finished. This also finished. Okay. Now I'll come for the signs and symptoms of the cardiac. Now assessment finding a maximum. What all the assessment we do in the cardiovascular assessment we have completed. Now we study the signs and symptoms. Okay. Sir, class will be like this only, sir. Okay. You will get a recording session, sir. I can't able to go more than slow this, sir. Okay. Some people are messing their classes going fast. You get recording session. This is very slow. Okay. How to find out DVD sign? You will get class in your regular batch. People, those are attending demo, they need everything at a single day. Yes. Okay. Cardiovascular sign. So it's very important as we discussed S3 gallop. Now we have discussed gallop sign. Whatever you said, S3 may be normal in the children, young adult, athletes, and the pregnant woman, right? S3 gallop. So, which I said, maybe major problem with the congestive heart failure, followed by maybe patient dilated cardiomyopathy also they can be able to assess. Mostly 80% patients with CHF. If CHF condition is not there, then you think about dilated cardiomyopathy, where you see the S3. Very rare. But S for gallop, it's a cardiomyopathy condition, hypertrophic, constrictive cardiomyopathy, or restrictive, sorry. Stiff ventricle, you have types of cardiomyopathy which we have studied. Okay, dilated, restrictive, and the stiffness. Okay, stiff ventricle is constrictive cardiomyopathy. That is also poor prognosis where we have seen S3 gallop or normal. What is pulsus paradoxus? Yes, pulsus paradoxus. Yes. Exaggerated decline of BP during inspiration greater than 10 mm of Hg. Greater than 10 mm of Hg. Okay. So what does it mean? Pulsus paradoxus, how you are going to assess? I told you during inspiration. Now I am checking the BP. Normally I am checking. BP is around 125 by 80. I am informing the patient to take take deep breath inspiration. Then I am checking the BP. BP is around 100 by 70 or 65. See the difference? 125 minus 100, 25. Or you can see 80 to 65, 15. Some changes are there. But here, exaggerated decline of BP of systolic BP, especially systolic BP greater than 10 mm of Hg is always considered the pulsus paradoxus. Not only 25 we need. At least if the BP is 95 by 90, sorry, 125. BP is 95 by 65 also, you can tell. Initially, I took BP 125, 125 by 80. After taking the deep breath inspiration, I'm checking the BP, and with the help of that shows around 105 by 70 or Jokia. See the difference, 20 difference. More than 10 decline of systolic BP is always pulsus paradoxus. Important question. The value they may be asking you 10 mm of Hg more than, yes, more than 10 mm of Hg is known as systolic BP. Very important. Exaggerated decline of BP during inspiration. Okay, greater than 10 mm of Hg. Right. So, which condition it is seen? Which condition? कौन सा condition में होगा? That is seen in your cardiac tamponade. Major conditions cardiac tamponade. Most commonly, pulsus paradoxus are seen in your cardiac tamponade. First question. Option में cardiac tamponade नहीं. If cardiac tamponade is not there, then check for the constrictive pericarditis. If it is there, you can take constrictive pericarditis. If it is, that is also not there, then massive pulmonary embolism condition. So it can see. Okay. So in the constrictive pericarditis, I added a Kussmaul sign. Special sign. Kussmaul respiration is different. Kussmaul sign is different. Kussmaul sign Distance, now only we studied distension of jugular venous. Yes. What is Kussmaul sign? Distension of jugular venous pressure during inspiration. Okay, Kussmaul sign. I have the image. I'll show. Okay, Kussmaul sign, constrictive pericarditis. That image I have, right? This one. This is known as Kussmaul sign. Okay, JVD distension during inspiration. Pulses alterance. There will be high pulse when you palpate. Pulse will be high and then low. High and low. Beat to beat changes in the pulses amplitude indicates left ventricle pain. Okay, so based on the indications you have to study. Beat to beat changes in the pulse amplitude indicates left ventricle failure. Orthopnea. Once again the question comes. Orthopnea. Difficulty breathing in supine position. Okay, difficulty in breathing supine position. What is that? So supine to standing position. Okay, supine to standing position. You get a difference of the BP. Have you studied hypertension? Difficulty breathing in supine position to the. So if I feel difficult when we stand, so they are comfortable. Difficulty in supine. So that is orthopnea. Don't get confused with orthopnea and orthostatic hypertension. Okay, orthopnea is difficulty breathing in supine position, which is seen in the COPD mostly and the left ventricle failure, which is seen in the COPD and left ventricle failure. So now once again you can Kussmaul sign came distant jugular vein during inspiration. Okay, consecutive. So as you said, some of the thing normal in adult S3 sounds are normal, maybe normal adults also. Okay. The S1 you have studied, S2 you have studied, S1, S2, where it is seen, S1 is louder than S2 in the apex, S2 is louder than S1 in the well, which you have seen in the previous assessment. Cardiac tamponade signs. So we have important signs of cardiac tamponade. So we have Beck's triad, which is 3 important signs: hypotension, JVD, and the muffled heart sounds. Okay. So whenever Beck's triad is seen in the cardiac tamponade, you should know hypotension, JVD, and muffled heart sound. Triad is, this is the triad. Option maybe they may be giving pulses, paradoxes, or anything, but this is the triad. Hypotension, jugular JVD, and muffled heart sound. Should not confuse with the pneumothorax. Muffled heart sound is diminished heart sound only during when the hospital dead they can see. Apical pulse usually pulse volume is good. Okay, muffled heart sound will be decreased sound of the apical pulse heart sound. That is a muffled heart sound because of fluid collection. Fluid collection mein dullness will be there mostly, and fluid collection will be there. When the fluid collection is there, they get diminished or decreased heart sound. That is muffled heart sound. So pulses alterance also we have seen, difficulty up and down pulse, beat to beat changes of the pulse amplitude. Okay, so it's an image I have added here. Okay, so this is the major sign, and then we have the sign. Yes. Yes. So we have the sign, 2 important sign in the Buerger's disease, PVD. PVD mein to both conditions will come. Peripheral vascular disease, one is Raynaud's phenomena as well as Buerger's disease. So when the Raynaud's phenomena questions are there, both are arteries and veins will be affected. But here, only arteries and arterioles are affected. Only arterioles and arterioles are affected. Which, when the arteries are affected, every nurse should know patient will go for cold encounter because vasoconstriction will be there. Numbness, cold, painful fingers and toes will be there. Okay, they avoid cold exposure because of vasoconstriction. So avoid cold exposure. Arteries are damaged. There is no point of exposing to cold. Vasoconstriction will be there. Condition will be worsening. So important intervention is avoid cold exposure when you see the patients with Raynaud's phenomenon. And WBR syndrome is seen in the Raynaud's phenomenon. Initially pale white, see fingers become white due to lack of blood supply, and then fingers turn into blue because of dilate keep the blood vessels in tissues, and then finally finger turns into red, blood flow will return. WBR syndrome is seen in the Raynaud's phenomenon. So Raynaud's phenomenon is a peripheral vascular disease, and you have arteries are affected, arterioles, no veins. Okay, and signs and symptoms.
White, blue, red.
Yes, white, blue, red syndrome will be there. Numbness, cold, painful finger toes will be there. And Burgers disease, all arteries, veins, and everything will be affected. Okay, arteries, veins. Yes, all will be affected. So Burgers disease, if you see, intermittent claudication, one word I am using here, intermittent claudication. What is intermittent claudication? Intermittent claudication, have you heard? Intermittent claudication. Yes. Pain at the buttocks of legs from poor circulation, impaired walking. Always they have the severe pain. Yes, pain in the calf muscle, severe pain always will be there. Leg, buttocks and leg region, poor circulation resulting in the impaired walking. Okay. So this is the Burgers disease. In the Burgers disease, arteries and veins both are affected. Don't affect over. Both are affected. Okay. DVT. DVT sign is different. Common sign. People are aware of that. Okay. What is the special finding in the DVT? Swelling, edema will be there. Swelling, warm, pain, tenderness, redness, pallor, everything will be there. Swelling, edema will be there. And Virchow triad is present. Virchow triad, though everyone knows the triad sheath. Stasis of the blood vessels stagnant hoga, hypercoagulative, coagulation, blood vessels increase coagulation, ज़्यादा होगा, it will get more coagulation, and endothelial injury, inner layer of blood vessels get damaged. Inner layer of blood vessels get damaged. Okay, so DVT, Virchow triad, venous stasis, and hypercoagulability and vein trauma will be there. That is Virchow triad, is very important, which is seen in the DVT. So DVT means how the assessment DVT and varicose vein. So DVT mostly confirmed by the USG Doppler, where the patient suddenly onset of pain and tenderness with the redness, pallor, swelling and edema will be there in the USG Doppler. Okay, when you see the assessment, usually confirmatory by the USG Doppler, and we have to manage immediately. Okay, measure affected extremity for swelling. This is what usually important. When there is a affected area becomes swelling and edema, patient is going for DVT. Okay. So only immediately we shift the patients to USG Doppler. Okay. Next sign is the pulmonary embolism. When you are not treating the DVT, the clot which is entering into right heart going to the lung and causing bilateral pulmonary embolisms, medical emergency, immediately it is dissolved by the dislodged clot from the DVT. Okay, no DVT pump, no DVT pump after the DVT. Before the DVT, prevention of DVT, we can use DVT pump. After the DVT, if you use the pump, the clot will dislodge and go to the lungs. So immediately pulmonary embolism patients suspected. For small quick review, I am giving this demo. Drug of choice is anticoagulants. Drug of choice is anticoagulant. When the patient is suspected, how we confirm the pulmonary embolism? Sudden decrease of PO2, SpO2 in the monitor, and increase of tachypnea, chest pain, sudden decrease of hypoxia, sudden saturation is falling, tachypnea, tachycardia, chest pain is there, hemoptysis is there. Is the clinical findings are important. Hemoptysis, blood in the sputum, sudden onset of tachypnea, tachycardia, and one side SpO2 is going down, 94, 92, 92. Immediately it's a pulmonary embolism. Okay, sudden onset of tachypnea, tachycardia, chest pain, pleuritic chest pain, sudden pain, severe pleuritic chest pain. So immediately what we do when you see this such a symptoms, we send the patients for CT angio. Confirmation is CT angio. After CT angio only, we have to start anticoagulant. This also question will come. How you are going to manage pulmonary embolism? Okay, so very clearly you have to study how you manage CT angio. They have to do, and then only we go for drug of choices anticoagulant. Anticoagulant we'll discuss in the regular batch. How you confirm the nurses are mostly prone for venous insufficiency? Major difference between arterial and venous ulcer. Arterial ulcer will be different, venous ulcer will be different. When the wound is there, you should know to assess the wound, whether it's arterial ulcer or venous ulcer. So, what is the special thing here? The client with peripheral arterial disease is instructed to elevate the feet at rest, but refrain from elevating from the above the heart level. Extreme elevation should slow the arterial blood flow. Mostly peripheral arterial disease patients elevate, that's a major thing. But how you confirm venous insufficiency and arterial insufficiency is very important. So, venous insufficiency because of varicose vein, ulcers will be in the ankle region and the tibial region. There is a venous ulcer will be there, which is brownish brown pigmentation, brown pigmentation. Okay, so irregular ulcer with the drainage, with the edema will be there. Venous ulcer, you get edema, brown skin feeling will be there. In the arterial ulcer, always in the tip of the finger. This is the important difference. Black spot, shallow depth, in depth, punched out appearance. Black color, punched out appearance. Gangrene type ulcers, intermittent claudication seen. Okay, and that is the finding for the arterial ulcers. Venous ulcer may edema will present. Edema will be absent. Venous ulcer may pulse will be present. Atrial ulcer pulse will be. So this is the three important finding. Usually we assess. Exam question. Usually it will come when you are assessing the atrial venous disorder. Atrial disorder, you get arterial pulse is 0, venous is present. Okay, and if you come for capillary refill time greater than 3 seconds, okay, and venous is less than 3 seconds. AB index, ankle brachial index less than decreased. Ankle brachial index actually in the leg they'll assess the BP, in the brachial they'll assess the BP, ankle BP and the brachial BP, and they'll compare and they'll go for the finding. But here, this is most commonly used in PPD only. In the arterial disorder, decrease. In the venous disorder, it is increase. But exam question is either edema or capillary filament pulse. Edema will be arterial disorder 0. Edema will be absent. Venous disorder it is present. Okay, this is the another important finding. Okay.
Great.
Audible.
Audible.
Okay, online students, good evening. Yes. So good evening for you also. So offline batch also we have some 4 or 5 students in Delhi. Okay, Delhi Chandrapur, and in Puducherry also we have this one. So some people have doubts regarding the upcoming course, which is for the ASI. Okay, and not set for 7, not for 6. Okay, this is the regular batch along for the JIPMER. JIPMER maybe June it will come. Not that you people are aware when it will come. Okay, September 17. Okay, so the course schedule, which I will explain clearly for this, those are looking for South ka branch or Delhi branch, dono mix hoga. But once the demo finished, the classes will be segregated. Okay, so NARS faculty will come for the Chandrapur branch to take class, and South faculty will go for Puducherry for tech. The demo is common. Okay, so demo is bilingual. English, most English will be there. Hindi sessions will be there after 6:30 if possible. Okay, so those who are looking for northern region batch online hybrid, it will be Hindi and English. Okay, from Monday. Okay, you can continue the same. Aapko to no issues. You can continue. Okay. So it's a 4-month intensive program, which especially content based as well as upro. You get complete this one MCQs as well as 90 days. हमने जो दिया 90 days today, which small demo as well as tomorrow. 90 days क्या है इसमें NORCET भी include होगा NORCET का, or it may get include for upcoming any exams you can use for any exams. Okay. So Monday to Friday same sessions 4:30 to 7:30. And last we get a 90 days बाद we get 30 days special program. That is what you usually tell crash course. So it will come around June. If people are eligible for ESA, I think. ESA you are eligible, right? You also eligible. NORCET. Okay. So ESA is we waited for a long time, 2019. ESA is the first rank 1 UP region for our students. So my students Rahul, 2019 batch. The rank 1 is from Metier. Okay. I'm not audible. Please join with your yes. Yes. So 90 days sessions I will explain. I'll give the syllabus. Then we can start the session. So uske baad we get 30 days. 30 days is your Google. Can you scroll down? Scroll your 90 days plus 30 days. Next PDF. Gokul, are you there? Please scroll down your PDF. Yes. 30 days intensive preparation course, which is included in this batch. Okay. Usually before exam, आपको ये चाहिए. This is very important. Whatever you studied for हमारा जो pattern है, whatever you studied, अभी what you studied maybe in the April, you may forgotten. Surely आपको एक boost up चाहिए. Okay. So as a first crash course trainer, Metier is the first crash course trainer from 2015. So I'm the one who started the first crash course in 2015. So we know what is the expert. And for new learner, myself Rajkumar Kanayan, and I completed my service in AIIMS last 10 years. And now recently I resigned the job so to manage my academy. So now recently, maybe last month, right? So I may be your special faculty plus for all the subject and MCQ revision. Maybe you may be studying something exam before you will be with me only. आप लोग मेरे साथ ही होगा. So I'll be taking mostly अभी जो ASA का भी. So we plan accordingly. Anatomy हम set of team हमने जो prepare किया, set of team will be that. The classes दोनों तरफ से होगा. For online students, we have 2 clear sessions. One is pure English. Okay, and other session is English and Hindi. Okay, जो English and Hindi है वो आपको दिल्ली में Delhi hybrid class है. Delhi offline, those who willing to come, they can come, and it may be offline. Delhi offline hybrid. Puducherry offline hybrid is only purely English. South का. I'm giving clear instruction. Those who are joined from South, अभी तो हिंदी में भी I want to discuss because there are students from other state also. तो दोनों mix है. Okay, so but once the classes start, both the sessions will be divided. Okay, South ka jo branches, those who need only in English, they will be joining the South branch. Those who continue with the Hindi and English, they will be joining the either Satrapur branch में join कर सकते हैं. मतलब hybrid. What is the hybrid? New learner, you get live class or recording, soft copy, everything, slides and everything. MCQs, test series before the exam, 30 test series as per the ESA pattern. Okay. So अभी हम लोग ये focus करेंगे. Mostly we focus only the upcoming exams, which is the ESA. I think NORCET will be September. There is no exam in between. Election will be there. So you have enough time to prepare for the ESA. Those who are preparing. So better prepare well. Now the pattern change हो गई ना. NORCET pattern change हो गई. NORCET is going well. New pattern 2020 series में live sessions going. As you all know that MCQ sessions going. Very well, morning 9 to 12, evening crash course is going. That is separately, it's going from the Metier side. Nearly 800 students are attending the session. Now, this batch we have started for the ESA, especially ESA, and we attend regular batch. A regular batch bhi hoga. Okay. So JIPMER with July, they said July. Exactly, हम लोग idea नहीं JIPMER का, but JIPMER, if it comes, will inform. JIPMER is separated. It is not included in this crash course. This is just purely for regular batch and the crash course before the ESA. Clearly, I'm giving ESA crash course because ESA syllabus is something different. No aptitude reasoning, right? Complete nursing subject will be covering. and Metier app access will be provided app access. Yes, Monday to Friday classes will be there, same like 4:30 to 7:30, and we get approximately 3-month duration regular course and 30 days intensive crash course. Okay, 30-day intensive crash course will be there. So my volume is good, right? Volume is good and everything is fine. And then once again, you have ultra revision course, which I said MCQs and test series and everything will be there. So this is what actually this ultra revision crash course only in June, because exam on July 7. Before boost up for your knowledge, हम लोग ये plan करते हैं mostly before that exam. Volume is low. I am okay only. Audible, please check it out.
Sir, volume is clear, sir. No issues.
Please message in the group. Tell them to increase the mobile volume. ये भी हो सकता है. Mobile volume increase करनी है. Okay. Gokul, if you want to purchase license, you can purchase, I think.
Sir, I'll call you, sir.
Call Dinesh and purchase a license, extra license, 1,000.
Sir, actually, I called him. He told me it is impossible now, sir.
Acha, okay. Okay, no problem. No issue. Subject pattern, आप लोग aware है ना? ASI का. ASI pattern is foundations. ASI pattern always you have to give equally 5 questions will be there. NORCET में ऐसा नहीं. NORCET funda message आते थे 60% funda message and then 5 questions. ESI they given clearly pathology, pharmacology, e-technology, pediatric, same content is same. Usually हम लोग यही बोलते हैं content तो same ही है. Heart and kidney, lungs are everything is same. Physiology is same. Only the questions may be changed. And कोई नहीं किसी को नहीं पता होगा. No one knows that the questions how it will come, because after 4 years ESI is coming. So I may tell questions will be like this. Questions opposite भी आ सकता है. UPSC they are preparing. Questions may be tough also. Who knows? Better we study everything. We don't want to focus only simple. We focus everything, tough questions, images, illustrations, images, and everything we study signs and symptoms, so that this 4 months you can get enough complete knowledge of subjects, so you can go with this. Okay, ये भी आपको easy होगा. सब कुछ we will cover it, and along with the physiology, anatomy, everything. So next, come for next. There is a grand test series will be releasing. Okay, along with the QA session. हमारा test series क्या special है? We do the QA session. अभी जो what is going, we launched the sessions. The next day morning 2 hours QA session. It will be more beneficial. No one is doing in India. We are the one who is doing. That will be more beneficial, because 3,000 MCQ with 2-hour live session QA session. No, so you each and every question answers it will be stored in your brain. Okay, that is more than you don't want to listen or look after. कोई भी questions आपको देखने की जरूरत नहीं. You can see our same questions which is we are giving. Okay, so today's demo and go for this. I'll start the demo. If you have any doubt, you can message the team further anything. Yes. So classes are mostly I will be leading faculty for before the exam mostly. And come down. Yes. So all the classes, new students, classes will be live classes. आपको तो people are aware. Old students आपको जो दिल्ली में हिंदी में चाहिए तो आपको live recording both will be uploaded. MCQs will be uploaded, and everything same like South branches also. Live classes will be uploaded. आपको class आपको app में होगा mostly. Like online classes, those who are preferring, you get Metier app download, and Metier app में you will get a class completely. After the class, आपको sessions you will get a like updated session. Recorded also you can see maximum 15 times. Okay. Some people are messaging, not hearing. Please check it out. You can message in chat box. Okay. So online hybrid class or hybrid class in we are having both Delhi Chandrapur as well as Puducherry Visayapur. Okay, so come last. You can come last. I will go for the session. Anything else to be discussed? Yes, regarding fee structure, now we decided to go with the same fee structure. We are not going to charge like 20,000 or 25,000 what others are charging. हमारा जो fee structure same for both the batches. Okay. So monthly basis 4,000, daily basis we go with the monthly basis. Students satisfaction is important. Students को जो satisfaction है वो important है. 30,000 अगर आपने दिया फिर बाद में आपका if you're not comfortable. Many of the students we heard अगर आपको comfort नहीं है तो फिर आपको जबरदस्ती you have to sit in the same place for another 6 months. So it is better monthly charges we'll take and we charge 12,000 per JSC. This 4 month complete package. Okay. So it is a complete low fee structure for across India. No one will charge this much and we give live recording, MCQs and everything. Okay. So based on the installment, we have given everything. Repeated students, whole students, right? So if you have any doubt, you can clarify from the speaker. Sorry, from the technical team. Okay. By this, any doubt you can ask. Otherwise, I'll go for the session. Yes, today's session. So how to register? Registration we have given here clearly. Fill out the form and enroll in your proper detail. Check the payment detail and you get app access within 6 hours. Okay. So you can go with the installment also, no issues. So Metier Academy app, download from the Play Store and आपने download नहीं. So best first thing because all the classes will be in the app only. Okay. All the classes will be in app only. Okay. Now.
Okay, sir.
Okay. So, we go for the session. Okay. I think any doubt you can ask the technical team.